Check. Yeah.
Good afternoon.
Hey, Mr. Brenner. All right. Good afternoon, everybody. Thanks for being here for Coalition Bargaining Session 2. I think we'll get started with introductions first, just so we all know who's here. Justin, we could start with you.
Justin Katz, Executive Director, Classroom Teachers Association.
Gordon Longhofer, CTA President.
Jim Pegg, Staff Association Consultant.
Heather Frederick, Chief Financial Officer.
Nancy Bolton, Director, Risk and Benefits Management.
Tim Kubrick, Chief of Human Resources.
Jordan Taradash, CEO of People One Health.
Leanne Lanano, Benefits Manager.
Jermaine English, Manager, Labor Relations.
Carol Sessions, School Police PBA Rep.
All right, and so online we do have Jesse Brown, President of ASOP, and Joseph Brenner, Chief Negotiator for SEIU, and Danielle Williams from our legal General Counsel's office. So thank you all for being here in person or online. We got a pretty packed schedule today, so with that, I'm going to turn it right over to Nancy Bolton to get started with our presentation.
Okay, good afternoon, ladies and gentlemen. Just to update you briefly with the data points that we've discussed in the past. So just topics to cover today: plan year 2024 and 2025 performance as of March. Rate change options. These are, just sketches to talk about what could be possible to cover the deficit. Proposals on how to slow down increases in the future. And then a presentation from People One Health. Jordan Taradash introduced himself. He's the CEO and founder of one of the options that we're exploring that we believe has some promise. So we wanted to have you see it as well. And just our red line changes, which are just updating dates, timeline, and discussion. So forgive me again for this very small font, but the good news about this, if there's any good news to share, is that March was a little bit better. We're advised by our actuary that early in the year, when we see these big variations month to month, they have a larger impact on the forecast because they affect the current year in a couple of ways. March, for example, was probably $3 million less than the actuary forecast in the beginning. So that is simply an improvement. But the $3 million improvement in a rolling 12-month forecasting mechanism or view, which kind of looks at a year in focus, so, March to March, April to April, May to May, brings our rolling, but the good news in March brings the whole 12 months down by about 1.5 points. And that improvement affects the forecast for all the remaining months of the year. And so early in the year, that affects a lot of months, right? So as we get deeper into the year, that piece of the projection will be less pronounced. And the forecast for 2025 is all driven by the rolling 12. And so this does look better a little bit, and it does impact a little bit the forecast that we discussed when we met in March. And so if we have better months this year, the forecast will improve, and if we don't, it won't. And so, of course, we can't predict the unknown.
But it is still projected to go up. I just
Well,
after
yeah.
all that, I mean, it is still projected to increase. And we are going to have some good months, and we're also going to have some bad months. But it is, overall, we are trending the same way that we were trending last year.
Right, so that is important for me to quickly go to this slide, because although the numbers, instead of 39 million for 2024, the projected shortfall, just in breaking even, and 54 million is less than 39 million as of February and 59, it's still significantly more cost anticipated than funding to cover. And the point to look at here on this slide is that blue trend line, which still has us below the state's required 60-day safety harbor threshold of claims both years. So even, adding these increases to the plan just to break even still leaves us at a funding deficit for both years as predicted. So the recommendations, now we're looking at a range in that 54 million to 59 million. The 59 is familiar. This is a range that is unpredictable. We don't know how the rest of the year is going to go. To reach the 59 million, as we discussed, this is a recap. The necessary premium increase based on current enrollment, which for March was 19,982 employees, is that $248 per month per employee, which is $124 per paycheck. But if we recommended a minimum of 55 million increase, split 50-50 between the district and employees, then that figure would be 116 per month per employee, 58 per paycheck for a 25-pay period.
And where the 55 is coming from is that we do expect that we're going to have good months and bad months, but the shortfall in 2025 is going to be somewhere between 50 and 60 million. So that's why we're just going to, split the difference and say that we're going to need $55 million to just break even in plan year of 2025. And so when you look at the second bullet point there, that is the per employee per month, but we're looking for the total amount that's needed, but we are looking to split that with the employees, and so that's where the difference, that's where you see the 116 per month per employee represents 50% of that $55 million, and that would be $58 per paycheck.
Okay, so last year you'll remember that we did rate scenarios. We looked at two options just for illustration. One was just a flat across the board increase regardless of what tier the employee chose, whether they were individual or whether they had a child or a family. And so these two red boxes show that $116 a month increase just flat, rate to rate, and then the column next to the red boxes show the rate reduced by full health rewards participation. And I do want to thank you for collaborating with us because we did see an increase of 1,000 members in our health rewards last year. And so hopefully we'll see even more because of the, the indicators going from 5 to 3. So just an illustration here. And then last year we looked at kind of tweaking the rates to consider the actual cost. So as an individual, I cost a factor of 1. That's what I cost. But if I have a child, then my rate is 1.64, where if I cover one adult spouse, then it is 2.14, just based on the cost of the plan. This is for illustration. The rates have not been drilled down by the actuary to really look at the true cost per tier. These are existing rates based on the actuary's recommended factors. But what it really has the outcome of doing is just kind of, if you look at the far right red box, it just shows the amount of monthly increase. So instead of 116 there in that high HMO individual, it's $96 of an increase, and 91 for an employee and child, and then more cost is on the employee plus spouse or employee plus family because you're covering more people. So this is just an illustration as what could be possible if you wanted to talk further about that sort of approach. The math ends up the same at the bottom line, so they're good illustrative points. And then just comparing the current to the flat across the board to the actuarial kind of factor, option 2. Okay. And then just the comparison again. I thought I was brilliant with the options in gray there, but now I realize they're kind of hard to see, so I apologize. They're just reflecting what I just showed you on the previous slide. But again, the story remains the same. These numbers are updated from the last meeting because Orange County Schools had to impose an increase that was widely reported. St. Lucie kind of also tweaked their coverage. It looks like they grandfathered their more rich HMO plan, and now they're doing high deductible plans only. So they have 3 different versions of those. But the story is the same, that the district remains very rich on the dependent coverage side as compared to our peers. These are just school districts that have faced what we're facing today, and this is how they've come out, where they're putting more coverage on individuals, and Broward, for example, doesn't provide any coverage for dependents. So they just, they cover their individuals regardless of what plan they choose. We, though, we're a family business. We subsidize dependent rates historically. So that, to me, is the main difference of this slide. Okay, so cost changes over the past 5 years. The left slide talks about our prescription drug costs. And as you know, the rebates have been getting larger over the past 6 months or so. And so even though our costs are going up, and our costs are considerable for our prescription drugs, the increase is smoothed a bit because the rebates are larger. But still, that's a lot of brand drugs in that experience. The medical claims, that's a little bit more pronounced, the increase over the past 5 years. And of course, COVID factors in that. So, and also medical inflation and post-COVID that we discussed last month. You had asked for the enrollment over time, so there it is. With our 2019 enrollment, the average was 20,600, and currently, well, I guess I didn't update that for March, but we're at 19,800 something right now.
982, right?
Yeah.
And then when you're looking at this too, I mean, it helps to point out what we talked about in our last discussion, is that prices are just going up just generically. So if you're looking at your cost of your prescription rebates, you look at the per employee per month, that is, the amount just keeps increasing. Looking at the medical claims in general, it's not just claims are spiking because enrollment is spiking. It's the per employee per month. You can see how that is just increasing each year. Because looking at our enrollment has actually declined and is now finally starting to bump back up again in 2020. We're in plan year 2023, so it is starting to bump up a little bit. We're at the 19,800, but still well below where we were in 2019.
Yep, and I see that I did add that little footnote down there with the 1982. So we asked United to kind of, because you all had said, what's causing these increases, and we of course follow you in wanting to know what's causing the increases. So United provided some cost drive, just a couple of slides. This one shows inpatient admissions, hospitalizations year over year, and you see that, I mean, there's really, costs are going up every single year. Admissions per 1,000, though, were actually higher in 2019 than they were in 2023, but the cost is higher. And the amount of days are actually lower by 6. The average days per 1,000 hospitalizations, but the cost, of course, is higher 5 years later. Average length of stay is a little longer. The average paid per admission, there's a jump there over 5 years, 20,000 in 2019 to 25,000, which is really high numbers. Hospitalizations are very, very, very costly to the plan. Admission paid per day, the per day figure has also increased. I mean, it doesn't tell a story you're not expecting it to tell. The total cost has gone up. There's nothing unexpected about this slide. And, you know, what we found is that there's really no particular cost driver. Everything is increasing year over year. Outpatient events, these are all separate. We asked United if emergency room, you know, or an urgent care where something was lanced, maybe, does that count also within the outpatient surgery numbers? But no, these are all individual costs. So outpatient surgeries paid, you know, it's a big cost driver to the plan, $20 million in 2023, up from $17 million in 2019. ER visits, as we discussed, they have gone up. Visits per 1,000 from 184 5 years ago to 220, almost 221 in 2023. Paid per visit numbers have increased. You know, the per member per month cost, and total ER paid in 2019 was just $11 million, and, you know, 17.6 in 2023. Urgent care, also going up, but it's a much lesser of a number. And now I'm questioning those numbers, the urgent care, because those, I'm sure that we paid more than 13,000 there.
No, it was in millions, so I think we lost.
Yeah, we lost, yeah, so we will correct that for the record.
But you could see during the COVID period how there was a swap between the ER and the urgent care, and now we're kind of going back to having a higher, we have a higher emergency room versus urgent care, because those are actually in millions on the bottom there.
Yeah. One of the observations that United made was that it seems to be people in their first year or two of employment that in larger numbers seek the emergency room. So education, I think, is an important opportunity for us to help to drive people to the lower cost options. Urgent care, they're PCP. And so toward that end, emergency room potential steerage, you know, in other words, if you're going to the ER, where would you be better off going for the cost of the plan? And even for your experience, because, gosh, going to the ER is sometimes not pleasant. So in 2023, visits per 1,000 were about 100. And the total visits in plan year 2023 were just over 8,000, and we paid $17.6 million. So there were 21 diagnoses that United identified that had the potential to be redirected to a lower level settings. So the examples are upper respiratory infections. United indicated that 95% of the time those could be treated equally at an emergency or at an urgent care or a private physician, personal physician. Viral infections, 80% of the time. Abdominal pain, 10% of the time. And if those visits were directed, there could have been 2,300 of the 8,000 that would have gone to urgent care, for example, and of that 17 million, potentially, you know, there could have been a 3.8 million potential reduction in the future cost of ER visits. So this is just a sketch of what could be possible. I think that there is a huge difference between the emergency room copays and the urgent care copays now, and so I think education is our opportunity there. And so, as you know, we are not currently proposing plan design changes as we sit here today, but we are looking at how do we slow down increases in our future plans, you know, fiscal year 2026 and beyond. What can we do to try to bend the trend? So if we're trending at 8%, how can we reduce that to 4% or, you know, lower than that? So we're looking at several things. We have Mr. Taradash here from People One, and he'll share a little bit more about his program. There could be some there could be an opportunity to reduce some of our costs and shift away from higher cost options like the emergency room and brand name drugs and other things. We're also looking at, there's kind of a new provider here in Palm Beach County, HSS Perform, and I keep forgetting what it's a hospital specialty Surgery, I think is what that acronym stands for. But they are a world-class orthopedic, they're ranked #1 in the treatment of musculoskeletal disorders, and that's one of our cost drivers. And so they have lower episodic costs. They boast Tiger Woods physician post-car accident, for whatever that's worth. But they offer,
You healed fast.
yeah, he did. He did. They offer kind of a concierge, so if you use, they're a center of excellence, and they would potentially maybe provide surgery less often and also help with continuation of care. And they are a United participating provider, so we are looking at partnering with them at no cost to the plan, just sort of an access education concept that drives people to this center of excellence. Also, United has enhanced their diabetes care program, and it's this concept of the thing, you know, that you put in your arm, the what is that? I don't remember the skin little circle, the little disc that we see a lot on people, and it actually is connected to an app that connects you to personal care, where the goal is to keep you healthy and to manage your disease more productively, so that our diabetes our colleagues with diabetes are trending about 13 or 14%, as compared to the 8% or the 5% that we've talked about before. And so that the intention here is for those comorbidities to be better managed, so that in the future, those people stay well and those costs don't escalate as they do. And then we had talked about prescription drugs. You all had mentioned mandatory mail order. There's new legislation that may challenge that as a possibility under the plan. You know, if you do mandatory mail order, you also have to do mandatory 90-day retail. So there's some considerations there that we're discussing with our consultants. The anticipated savings, or impact of the cost is not as, remarkable as some of the other potential things. You know, I think 250,000 was a potential impact to next year's costs for mandatory mail order if it is something that we can do under the plan. United, though, talked about a different platform. Now, this is I'm sharing this with you just for your knowledge, but it would be a prescription drug platform shift from the current formulary to a different formulary that would have the impact of, moving certain drugs into different tiers of coverage. And so there would be different cost points for some of them. About 100 of our currently covered drugs would be excluded, but there would be an opportunity for doctors to kind of plead the case to get them covered. And so there could be an opportunity there. The future cost impact was, when looked at under our rebate schedule, was maybe around the $2 million potential impact. So, it's just something that I'm sharing with you as a information point, because I think we have to consider everything now. And so at this point, I think if Jordan would jump in and let me kind of see how we can get your presentation loaded. So, okay, there we go. And
It's a PDF on the bottom.
PDF on the bottom, right here.
Yep.
Oh, that was easy. And just make it, there we go. Okay.
That'll work right there. It might not be a clicker. It's a PDF. Oh,
Yeah,
is.
it
Oh,
works.
it is. All right, good.
Perfect. Okay, hi, everybody. I'm Jordan Taradash, CEO over at People One Health. I appreciate so much the opportunity to chat with you all. Just a quick background before I dive into the details of how we might be able to support your members in your plan. My mother was a health and phys ed teacher in the New York City Public School District for 31 years. To this day, a proud member of her Classroom Teachers Association union. So I personally benefited from all the work that you all do here every day, and it's become my and our company's mission to provide the highest level care that we can to your folks while potentially helping to mute the impact of some of these increases that you see year after year. So thanks for the opportunity. I'll walk you through this, but please ask me any questions you have along the way. The overall theme of this presentation you see in the top left here is you deserve better. And this is a royal you. Every single person in this room and all of your members, we fundamentally believe you deserve better in terms of care and quality. And let me walk you through how we do that. This is just a quick summary of what Nancy walked you all through here, right? Over the last decade, healthcare costs have gone up 53%. The average family is approaching $10,000 in out-of-pocket expenses. By 2033, the estimates are the total family premium is going to be equal to 100% of the median family's income in healthcare expenditures. So I'm sure you could all see how that's just fundamentally unsustainable. About 40% of folks in our country are what are called functionally uninsured, meaning they have an insurance card, but they can't afford to use it because of copays, deductibles, and coinsurance, because they make choices to buy their children baseball bats and dresses for prom and whatnot. And those are decisions that we don't think anybody, in our country should have to make. And then for all those cost increases, you've all experienced this, where you go to the doctor, you spend more time in the waiting room than you do in the actual care, and you run out of there with another prescription and another specialist visit. And it's just not the best experience, to say the least. Okay, so this is what we attack. This is why we get up every day. So I'm going to run through kind of this compare and contrast. This is a little bit of what we don't do and what we do, and I think this helps tell the story. The number one most important thing on the top left here is we do not replace your health insurance. Your health insurance plan stays in place exactly as it does. This is an enhancement to that health insurance plan and the care that you folks get. All of, or the vast majority of the costs that you're seeing there run through the current healthcare system, which is under fee-for-service. Fee-for-service is a volume-based incentive, meaning the more care your folks receive in the system, the more revenue that system makes. We personally feel the incentives should be backwards. There's the other way, that the healthier your people are, the more money the system should make, and the less healthy your folks are, the less money. So the incentives should be aligned, right? You folks should be paying for your people getting and being kept healthy. That's how we are compensated. People One Health, if we choose to partner with us, is paid in a flat rate, meaning unlimited access for one set dollar amount. Full transparency, my organization makes more money the healthier I get and keep your people. That's how we make money. We don't build on-site clinics that are just for employees, because usually about half of the covered folks on your plan don't come to work at your buildings each day. They're covered spouses and family members. So we build multiple offices spread throughout your community in partnership with you, so these are accessible to all family members as well as your employees. This is not urgent care or a hospital system, but as you saw in Nancy's presentation, there's a whole lot of care going to urgent care and ER, and fundamentally that's because people can't get into primary care. They don't have a relationship, it's impossible to get in. The services I'll show you have been shown to reduce urgent care utilization by 75+% for members who are using it, and ER utilization by 25%, because people can actually get into primary care and get the care where they should be. And the last point, this is a lot more than primary care. I'll show you that in a second here. Okay, there's a lot on this slide, and my apologies. I'll walk you through this slowly, and the colors are pretty vibrant. So for each community that we serve, we build these community-based health centers in the community. And if your members choose to engage, and I say choose because this is completely voluntary, none of your folks will ever be forced into this. They get to raise their hand. But if they do, this is the service they'll get. They'll have unlimited access to their primary care physicians. Our physicians see no more than 16 patients a day. So that means your members are going to have 30 minutes, 45 minutes, an hour, real-time slotted for their care to be heard and listened to and cared for and navigated through the healthcare system, not these 7-minute appointments. They're going to have a deep one-on-one relationship. Some of you folks have gray hair like I do. Remember the days when your family had a primary care physician that knew your mom and your dad and your whole family. This is that type of primary care. It is a deep relationship with your members and their family. Generic drugs, if folks engage in this, either dispensed at the office, community pharmacy, or mail ordered, are all included. There is no cost to your members for those, and there's no cost to the plan. 99.9% of labs, they're drawn at our offices. You don't have to go to another facility for that. All included. Your members will pay nothing for those. The plan pays nothing. And then this bottom point, care coordination. About 30% of folks in a primary care office, or really any healthcare office, are doing billing and administration and insurance. There's no such thing in our office, so our people are doing healthcare navigation for your folks, making sure they can help get those appointments, guiding them through their care experience. Okay, that's the top level there. Any questions on the blue box before I go to the other two?
How many locations in Palm Beach County?
None as of today. So what we will do for you folks is, if we choose to work together, you'll see this a little bit later. We see where your folks live and work through heat mapping, and then together we will start locating our locations so they are convenient for the folks. We're proposing to start with 4 facilities in and around your county here. Thank you for that. Okay. I told you my big secret. I make more money the healthier I keep your folks. So that means you're going to get a primary care physician, you're going to get a registered dietitian and a health coach. You're going to get a licensed clinical social worker as part of your team. We are preventively screening everybody for substance abuse and behavioral health challenges that is under our care. So if anybody is screened high, the primary care physician and the social worker come together, give a brief intervention, and get your folks into the care they need immediately. We don't just send you off and say, good luck in getting into therapy. We are managing your health care and your behavioral health together. Clinical pharmacist, can you afford your medications? Are you filling your prescriptions? Do you have adverse interactions? You have this concierge care team guiding your folks through all of this care. Specialty consults, you've all experienced this, right? You have to go to different specialists. It takes months to get in there. There's more copays and the deductibles. If your members are using People One Health, our primary care physicians have access to 75 subspecialists to do curbside consults. That means your blood work comes back a little bit off. We don't just send you out to an endocrinologist. Your primary care physician is going to consult with an endocrinologist and say, can I manage this through primary care, or do we really have to send them to a specialist? So we're not sending your folks around through the carousel of care. We are managing it every step of the way for your folks. Okay, green bucket. Any question on the green bucket? Okay, the bottom bucket, I have no idea what color that is, but this is where we go farther. Mustard? Okay, it's mustard. This is where we go even farther. So if your folks need outpatient behavioral health therapy, physical therapy, advanced imaging, CT scans, MRIs, X-rays, cardiac testing are like stress tests, pulmonary services are like sleep studies, durable medical equipment, CPAPs, wheelchairs, braces, all of these services are included for your folks if they choose to engage in this model. They pay nothing for all of these services. Your plan pays nothing more. All said and told, all of these services are about 88% of all of the healthcare that your folks may need in a year is all through this concierge model. It's about 40% of the total cost that's typically hitting your plan is now pulled out and all encompassed in one flat per member per month rate. Okay, I said a ton there. Any questions, other questions I can answer for you on all of this?
Yeah, is the hardware also covered under that stuff? Like
Your
machines
CPAP
and
is
so forth?
included, yes, it is, all included in this. The whole point of this model is remove the barriers so your people can get the care they need. Take away those barriers. Yep. Okay, I can come back to this at any point. So to your point, sir, on the left side here, everything I just described for your members, there's no co-payments, there's no deductibles, there's no paperwork or bills. We're removing the financial barriers because the more your folks use the services on the left here, the less likely they're going to be in the urgent care or the emergency room or have ongoing chronic disease. So we want them to get those services. We remove the barriers. On the right side, though, God forbid your folks need to go to the hospital or the emergency room, they still have their health insurance plan. It is still fully in effect. You just have this concierge model that's helping them through the day-to-day stuff. Put those two together, you have all the health care needs for your folks. Okay? Sounds good to be true? Yeah, it does, right? I'll show you some data that proves that it's not. Okay. let me give you a little story here about fundamentally what this feels like for your members who choose to engage. So this is theoretical Danny, and imagine Danny's one of your employees here at the school district, and after school one day, she was playing with her kids and she hurt her shoulder. Typically, you know the experience. Danny cannot get into primary care, so she ends up in an urgent care center. There's a copay with that. She gets pain medication. Then they refer her to an MRI, weeks to get in there, more expense, and then physical therapy, more expense, more time. Overall, the total cost of that episode is about $765 to Danny and about $2,800 to your plan. If Danny chooses to be a People One Health member, this is what it'll feel like for her. She will get into her primary care that day. Same day, next day, we will get your folks in. She will pay nothing for that experience. The pain medication that she needs, nothing for that. If she needs an MRI, we are setting that up for her with proprietary access with our partners. She will get in there. When she gets there, she pays nothing for that MRI. It's already included in the bundle. The plan pays nothing more for that. Let's say Danny does need physical therapy. Instead of the plan saying you get 12 sessions, there is no plan in the middle here. The physician and Danny will decide when that care is done, and then that's how many sessions. There is no limit on it, no cost to Danny. So on the bottom right here, you see how the economics of this potentially work. Danny pays nothing for this entire care experience, and an entire year for Danny in this model is $1,800. So you can start seeing how some of this really potentially saves money for the plan and saves money for Danny. I want to be clear, the $1,800 is paid for by the plan. That yearly membership is paid by the plan, not by your membership. Okay, this is the aspirational goal, right? Really enhancing all of the experience for your folks, their well-being, the productivity, and furthering your plan of attracting and retaining the best folks out there. I have like 2 more slides and I'll stop, but okay. Forget about all the math and the jargon that I just threw at you. Let's just talk about how your people will be cared for. So the average Net Promoter Score, customer satisfaction score of the healthcare system right now is 35. It's kind of okay. The average Net Promoter Score of a health system-owned primary care office is 3. It's quite poor. Cable TV customer service is the only thing that's worse than that. That's not a joke. That is a literal fact. Our members rate our care at 87. It is the fact that your members will be heard and listened to, cared for, advocated for. That's the real disruption we want to bring to your folks. The cost savings and potential of that, whatnot, is really a byproduct to the care that your folks deliver and deserve. Okay, I have some numbers to share with you all, but any questions I can answer for you all kind of overall about how this works before I show you some numbers. Good so far? Okay, thank you. All right, so this analysis is based on your actual claims experience from January to the end of last year. Okay, there's a lot of numbers on this, so let me walk you through this nice and slow. So this is about the potential future impact on cost increases. So you see the year after year after year, about 8% increase. The idea here is that if this coming together can be, a support for your school district and your members, it's a potential to blunt that. So I'm not going to say costs won't go up, but potentially instead of 8%, they go up 2%. So let me show you how that works. In the top left corner here, with only about 10% of your membership opting in, saying we would like to do this, the plan would potentially save about $1.8 million, and your members would potentially save about $2.4 million because all of those services we went through, there is no out-of-pocket anymore. You can see 10%, 20%, 30%, it's pretty linear. As more of your folks choose to engage, the potential savings to your plan increase and the potential savings to your membership increases all the way up to, we modeled 30% here because historically with other school districts that we've partnered with and deeply partnered with the administration and labor to drive engagement, we see aspirationally we can get 30% of folks in year 1 potentially engaged. If that is the case, The potential impact to the plan is about a $5.2 million savings, and the potential to your members is about a $7.2 million savings, because that wipes away all of those out-of-pocket expenses for all those services. A lot of numbers on here. Anything I can answer for you on all of that? Okay. This is just one more graph. So the top is really just illustrating. The top line is what happens if your plan expenses continue to go up at about 8% year over year over the next 5 years. The blue bar is if we partner together and start engaging folks in this higher value concierge model, is the blunting of that. So the cost increase at about 2%. So you see costs are still going up, but they're not going up nearly as fast, which is obviously a benefit to the plan and to your membership. On the bottom is the cumulative impact. In essence, the difference between those two lines. You can see year after year the cumulative impact of blunting that increase between 8% and keeping that down into a 2% range. Okay, any questions on this? Okay. Sir, to your question, this is a heat map of where your folks live throughout the region. So we will partner with you all in saying, hey, where is the right place to start? Let's place the first 4 offices in regions that are convenient to the greatest percentage of your membership, and that will help drive the voluntary engagement in this. That's where we'll start. These are multiple employer shared offices, so you do not pay for the expense to build these. We pay for the capital cost. That does not come out of your budget. That comes from us. And we look to build more and more critical mass in a region as we partner with more and more of your folks. I think that's it. That's all. I'm happy to answer any questions I can for everybody. And thank you so much for the time.
So the reason why we presented this today was, give this as an option. It is strictly voluntary if it is something that you wanted to pursue. We would have to guarantee 10% participation of our membership. So that would be about 4,000, because it's total membership. It's not based on employees. So we have about 35,000 members, 38,000 members right now. And so we wanted to gauge your interest as to whether this is something that we would want to pursue, because it's where in the slide it talks about employer costs or employer potential reduction in costs. It's really the plan, and we're trying to, and this goes to what Mr. Katz had mentioned in the last meeting, is it's not sustainable to have these 8% increases each year. So what can we do to try to get back to where we were, which is we were having 2% and 3% increases in the plan each year, which is much more manageable. This is something that Orange is pursuing. What other districts do you work with in Hillsborough?
School district of Osceola County is a current client. Orange County Public Schools is a current client. Those are the 2 school districts currently as clients in the state of Florida.
And it would take 9 months in order to, find the locations and actually get this started. So we wouldn't be able to see, any potential reduction in costs until plan year of 2026 is what we would be looking at. But like I said, we'd have to make sure that there is an actual, that you would actually want to participate. This is something you'd want us to pursue, because we would have to guarantee a participation of 4,000. And if we didn't have that participation of 4,000, it is still a plan expense each year that would come out of the health plan.
So clarify for me if I'm understanding, if someone were to choose to utilize this service, they do not have United Healthcare.
No, they do.
They
They
keep
do.
everything.
Okay, so it is, they would
On
pay
top of.
the monthly or annual that you mentioned, the $1,800 for this to
We pay
enhance.
that. The
Well,
employer
it would
pays.
come out of the plan. It would come out of the plan.
Okay,
And so instead of, where they were looking at the cost, because right now we reimburse United Healthcare for the actual costs of whatever the claim is. And so with this one, we would now be restricted to the claim is only the $1,800 per person per year. And so that way it's, if they were to go and use, which they still would have the opportunity to use any doctor that they wanted in United Healthcare. But if they were to just stay within this program, if the costs utilizing outside the United Healthcare could have been $5,000, but we're capped at the $1,800.
Okay, so I have United Healthcare, I opt into this, the district pays,
The plan pays the $1,800.
understood, so it's,
Yeah.
but by opting into this, I don't pay as the user,
No, and then you have no co-pays,
as long as you go through.
as long as you go
Obviously.
through this, yes.
So if, in a scenario that I need emergency room care, I injured myself, my knee needs all sorts of surgeries, what is the cost to the plan? Nothing above the 1,800?
Yeah, so that's a wonderful question. The surgery would fall on the right side here. So that would hit your plan just like it does today, identically. So the plan would just pay identical. However, importantly, let's say before that you needed some MRIs before your surgery. That would already be included. That's included, no cost to you as a member, no additional cost to the plan. You need physical therapy after your surgery, that's already included, so there's no additional plan. So it really narrows your plan's exposure to these variable costs, and it reduces the exposure to your membership from cost.
Understood. You had mentioned earlier in the presentation that something to the degree of 80% of care falls under what would be the plan's $1,800, or whatever the fee coverage is.
That is correct. I do want to add one other piece. The guarantee membership is only for the first year. After that, that is on us, so it's only a 1-year guarantee.
So going back, and Justin pretty much asked the questions I had, but, so we're going to need people to make a commitment that they want to go toward People One. Is that what we're saying, is before we can actually make a deal with People One?
Well, I would say we would want to gauge the interest, because we don't want to all of a sudden, only have 1,000 people want to participate or 500, and we're guaranteeing that first year, the 4,000. So if it's not something that the membership is at all interested in, then I don't know that it would be something we'd want to pursue. I'm sure you have another response to that, but.
We've been doing this for 12 years. Many school system partners, many public sector partners, and some private sector partners. The unfortunate reality is, even before the pandemic, 55% of folks did not see a primary care physician. It couldn't get in, didn't have a relationship. When you give your folks the option, because it is completely an option, to join this concierge-like model, and it removes all the cost barriers, that's why we modeled 30%. We typically see 20 to 30% of folks say, I'm going to give this a try and do this. So 10% historically is a very modest voluntary opt-in that we see.
And then you keep using this word concierge. I just might be cautious with that, because me as we'll say as an average person receiving care, when I hear concierge, I hear someone tell me I got to pay $6,000 extra a year. So concierge sounds like something that's going to cost me more money, rather than give me a better deal, or we'll say completely limit my out-of-pocket expenses. So I think one of the things that would be important to the people around this table is, who's making the decision to go to People One? Are we making a recommendation from this group, or is this something the board and the staff is going to make a recommendation on?
I mean, ultimately, it is all up to the staff and the board in order to make that decision. But we want to gauge the interest for participation purposes. I know that when I watched this presentation, I went into it, not expecting to be impressed. And I walked out saying, if you can do exactly what you say you're going to do, it's impressive to not have any co-pays for the employees, to have everything covered. That would be a nice benefit for our employee group. So it's more gauging. We will have to, in some way, I would say, send out a survey. I think that's what you said they've done before, to employees to see if they would be interested in it. It is a communication.
Yes.
And getting to our employees and being able to communicate to all of our employees, I think, will be the challenge, the main challenge. Hearing it, everyone that we've talked to about it within the district has been very excited about the potentials for this program.
And I agree with you, Heather. I think the issue, Nancy repeated several times, education. I think the only way this works is if we educate our employees so that they're going to be receptive to this. Because I don't know, what's the word I want to use? Most people are skeptical to change their direction when you talk about their health care. I mean, I'm an old guy, so I remember 100 years ago, we went from, I forget what it was even called, preferred provider to HMO. And you made people make choices, and no one knew whether they were making good choices or not. I think that's really what's important here, is making sure that people understand whether they're going to make the good choice of what's going to be best for them. You know, yeah, obviously, anytime we talk about less money out of pocket and quality service, people are going to be interested. But I think it's going to take a lot of communication, a lot of education to get people to understand really what this is going to be.
I couldn't agree with you more. And although it's like, at some point, it's like 9 months, we'd love to get going. Part of what's good about the 9 months is really us partnering with you and getting into community events, talking to your folks, letting them meet our physicians, because that communication and engagement is so crucial. And your feedback on concierge, right? That's why I need you to tell me, here's the words, here's the partnership. It's your partnership and the language and the experience and the marketing campaign. That's really what we need to partner with you all to do. So I could not agree with you more.
Well, the other thing that'll be important for the people that want the healthcare services, when you look at your heat map, is where those places are going to be located. You know, this is a big geographical district that serves a lot of people that live in a large area. You can see that by that map. And surely when we look at it, you see hot spots of Wellington and Royal Palm and things of that sort. But if you ignore the north and the south, you'll fail. You're going to have to figure out a way to get them involved too. So
Appreciate all that feedback. One last point. Because this is not health insurance, to your point, sir, each month folks can opt into this. So let's say the first month a bunch of folks opt in, they're going to go experience it and talk to everyone at the schools. The next month, more people can come. Word of mouth is truly our #1 spreader of this service.
It's
And
not
that's an
limited to, it's not limited to just once a year. You can opt in and out throughout the year.
I think
forgot to
that's an
mention.
important thing to share, because people are afraid that, you know, we make a decision, am I stuck in this decision for the next 12 months? So to know that you can basically waffle around and make it work for you and your family, I think that'll make a difference in whether people accept it.
Thank you for your feedback.
And then also other sites would be added based on the amount of participation at each site, right? So
Yes,
once you
great.
reach a certain utilization, you would automatically add another site, which would then not be an additional burden for the district plan at all. That would be absorbed, other than the additional members that are participating.
Selling point's going to have to be, okay, we're going to have to increase what individuals are going to have to pay for services. I mean, that's clear from what we
Premiums.
see. How are we going to, you know, less money out of pocket for services is going to have to be a biggie, because that's the only way you're going to sell this. You know, look, I'm paying $112 more than I paid last year, something like, you know, that's going to, you know, fry some people's minds. So when they need to know how they're going to have less money coming out of their pocket.
Well, I think this is a perfect example of that, right? So with the increased premiums, but when you're talking about going to the doctor, not having to pay a copay, not maybe one MRI makes up a huge chunk of it, right? No, your prescriptions, things like that. And actually, like you said, being able to get in to see a doctor or get a regular physician is something that's kind of difficult to do.
Right now.
Mine retired 2 years ago, still don't have one. So.
And if I could just quickly hearken back to the point that United made, that the new employees seem to be the ones going to the emergency room. And as a relatively new employee, 2.5 years now, so I can't, you know, claim new much now, but I've had a hard time finding a PCP under our plan, and the ones that I have found have wanted the concierge payment. So, you know, I just, to share those two data points, I think it's important. It could be an indicator.
Yes.
So two questions, one maybe for the district, and then another one regarding the service. In reference to the question that was asked about who makes this decision, you said that this would be and I'm just asking this, I'm not reflecting a position or anything, you said this would be a unilateral decision between the board and the administration, not the coalition?
Yeah, this is not something that would need to be bargained as part of the coalition. It would just be gauging interest.
Understood. And then, I guess a question as to the statistics and the potential savings. think it said that if 30% of the employees, or not the employees, but if 30% people covered, employees, dependents, shifted to this, the savings would be in the realm of $12-13 million. But I know it's not like a dollar for dollar transaction. If 30% of people get this, it reduces cost by 30%. But it seems like in a $220 million self-insurance plan with escalating costs, that if a third of the people leave, is it because people who, I use the word leave, I'm sure that's not exactly what it is, I get that. Is it that the most expensive costs, like emergency room, which don't fall under this, like, you know, those people are still, those 100 people, because the way that some of this works from how it's been described to me over time is that we might have 30,000 plus members on our plans, but there might be like 100 people with severe medical needs in a given year that drive like the majority of the costs. Those costs ultimately don't get mitigated by this because they're in that piece of the pie on the right-hand side.
It's a really good nuanced question, and I'm going to try to give you a nuanced answer if I could. So let's go back to this slide here. This is 88% of all of the care, but it's quote-unquote only 40% of the cost, because you can see the stuff on the left here is not open heart surgery, right? So we are disintermediating 40% of the cost out of the planned fee-for-service, which is a significant portion of the cost. We cut that cost about in half. The plan would have paid about $4,000 for all that care in the typical system. We're going to give it to you all for $1,800 and cap that. I'm going to take the risk on the rest of it. However, if you do need open heart surgery or catastrophic cancer, that stuff still hits the typical plan as it is. That's about 60% of the cost. So that's why it's not as dramatic as you think out of the gate. However, because after year after year after year, then we're going to start working on preventive medicine and controlling type 2 diabetes and hypertension. That's why your urgent care and your ER utilization and all those services, those potential savings do accelerate. Out of the gate, we're giving you a better price. Over long run, we're delivering better health care to your folks. Does that kind of make sense how that comes together?
Yes, I appreciate that.
Great question.
Within the realm of what's capable for a government like the school district to identify employees who might mathematically benefit the most from this, what can the district do to do that without digging into people's medical histories, but looking at costs maybe associated with names, if that's information that, like, how would we make sure that we targeted, like, somebody might not think they're interested in this, but if you showed them a figure that, you know, it's clear you spend $6,000 a year, but through this, you would not spend that much.
Yeah, you can't do that. You can't target individuals,
Understood.
because all of that information it's confidential. So that's not something that we can do. But so that's where the challenge is of educating people and then trying to give examples. And that's what when we saw the presentation, I think we had 3 different examples of different cases of this is what it would look like if you had this type of injury. This is what the out-of-pocket cost would be for you under your traditional plan. This is what it would be under this program. But yeah, I don't believe that we could actually target individual people.
Could the opportunity be presented generically to employees to sit down and discuss voluntarily, if I wanted to evaluate the benefit of opting into this, and in that meeting, I'm willingly discussing my medical needs, and is that something that exists?
So there's actually a really data-driven answer that fits right in between this. So I don't have this slide. I'll send it to you all after. Because what you're describing, sir, that kind of think about the math where you're saying, like, hey, if I'm spending $5,000-6,000 a year, I'm probably battling some illnesses and I'm spending a whole lot of money over here. And then you all say, hey, here's an option to get all this care for nothing. The data shows year after year, we actually get the folks who are older, sicker, have more chronic disease, more medications because they're getting killed by the finance of the system. So that's the natural migration in the beginning. If all we got was your youngest, healthiest folks, I'd actually increase the cost of your plan in total. So the good news is you actually don't have to do the targeting. The economics of healthcare does the targeting for us, and you'll see that. And I'll send you the actuarial data on all that. That's great.
I appreciate the responses.
That's a great question.
Yeah, so I have a question. Since it seems like you have a lot of upfront costs that you're laying out, is there a term on the contract with you guys? Like, you know, is it a 5-year term, 10-year term? Because right now, with the challenges of United Healthcare and the cost going, you know, through the roof on some level, we don't even have the option to shop. So we have to wait for that contract to expire before we can even consider it. So what would that be?
We believe in healthcare by choice, not healthcare by whatever you would call that, what you described. So although we are, you know, none of this is official, we typically look at a 3-year contract, but only that first year is when you're saying, hey, to offset the capital expenditures, we're going to guarantee this minimum membership. After that, the plan is only paying us for the folks who are saying, I love this and I'm using it. So financially, although we're kind of saying, hey, we're going to commit to an initial 3-year period, the truth of the matter is in year 2 and year 3, you're only paying for the membership that is saying this is right for me and my family. So I don't know if that makes sense, how those economics work.
Yeah. So are we paying for the minimum amount of folks that have to sign up for you? So if we dip below that level, is there a cost increase?
So only for the first year, because year 1, we're going to come in and spend millions of dollars, open up these facilities, hire care teams. So for year 1, the partnership that we asked for is 4,000 members. So it's 1,000 members per office. That's the kind of minimum. So let's say only 2,000 people raise their hand. You're still going to pay for 4,000 for that first year. That's the quote-unquote penalty or minimum cost, I guess you could say. Yep.
Thank you.
Yeah, great question.
And then just to clarify with United Healthcare, I mean, we are a self-insured plan. So we went out for an RFP, I believe it was 3 years ago. The union groups were included on that RFP. They were included in hearing all the proposals from those insurance companies that bid. And we use United Healthcare to just administer our plan. So we reimburse them for the actual claims paid. United Healthcare is the one who goes and negotiates with the doctors, the hospitals, and whatnot for the price of the service. But we are a self-insured plan.
We couldn't get out of that management contract either, though. We have to wait for that to expire.
We do have to wait for that to expire, and I believe it's a 5-year term with the option to extend for 5 years. And, you know, just to.
Whose option? Just United Healthcare or Mutual?
It would.
The board's option. I mean,
Well,
it's
and,
not-
it would be mutual. I mean, if United Healthcare didn't want to continue it, they wouldn't have to continue it. I don't know that would happen, but there was, oh goodness, now I lost what I was going to say. All right, when I think about it, I'll bring that back up again.
Okay, I had another question. So as people, and I want to make sure I do this, people one, for some reason I want to say people soft. Well, is people one, no, might want to rename it. Will this be an exclusive, people one will always serve the school district of Palm Beach County, or will there be other organizations, maybe Pratt & Whitney or somebody like that, that would join in with you on this?
For multiple reasons, we have multiple employers share this. Number one, the more the employers that share this in the community, the more likely it is not only to remain, but to grow. Our intent is to build many, many more offices than 4 in your county, so it becomes more and more convenient for more of your folks. So we usually partner with public sector partners first, counties, school districts, and whatnot. And we're going to give you all first right of refusal. If you all take this partnership with us, the first opportunity to raise your hand is for this school district. Once all your members have kind of taken their seats, then other employees will have the option, but you all will get the first take at those. But yes, we do partner with other employers in the region to make it sustainable and grow throughout your county. We will also deliver a performance guarantee, a contractual performance guarantee that for every dollar you pay us, you will get that returned dollar for dollar too. So we really put a floor to your risk. That's how confident we are that we're going to do right by your folks and your plan.
What other public sector entities are you currently contracting with, or in what regions or states?
Yeah. Pennsylvania and Florida are our two states, so we have over 100 clients in Pennsylvania. We started there. We came here about 2 years ago, so the school district of Osceola County in Osceola County obviously is a client. Orange County Public Schools is a client. Putnam County Government is a client. So those are all contracted already clients, and there's numerous other school districts in Florida. This state is is my number one focus right now. Yes.
A pretty direct question. Would you share after this meeting some of those clients in Pennsylvania?
Oh, for sure.
Great, thank
Happy to.
It sounds intriguing on its face. I mean, it sounds like one of those too good to be true type scenarios, so it's not to be skeptical, but at the same time, to be a little bit. But I appreciate everything I've heard, and if it's as good as it sounds, obviously, it would be of benefit, it would seem.
That's exactly what I said. Pretty much exactly what I
I
said.
used the word promising.
Thank you all so much. Appreciate the time and questions.
Thank you.
Uh-huh. Yeah, that's where we left off. Thank you, Jordan. We appreciate you. Okay. Right, so, that really was, that was it. The general, I don't have redlined articles, although we would love for you to, we would hope to resolve this quickly, but, we're just proposing updating dates and that kind of thing.
Any other discussion based on the premium increases that are recommended here?
Again, speak for the coalition, but certainly at this time, in this point in the calendar year, CTA is happy to listen to all information that better informs any future decision.
I'm not sure what you mean by that.
That we appreciate the information, but as far as discussing or entering into actual back and forth negotiations, right now, CTA is more interested in seeing additional data from some upcoming months.
What data is it that you're looking for?
Just the additional monthly,
The
expenses.
premium-
Yeah.
Expenses?
Yeah.
Okay.
Especially
We
in-
have been sharing that month by month.
Understood.
We have the March ones that are coming out.
Understood. And especially in light of the dip and what hopefully would be some sustained dip like that, and the impact on the actuaries' investments, or projections, rather. So, yeah, we're open-minded, but at this point, CTA, and I know that there had been a communication, I believe, from PBA stating that they similarly, they did not feel they were in a position to make decisions at this time. I think that email went to everybody.
Okay. Well, we are here at the bargaining table to bargain, I believe, right? And to reach an agreement on our upcoming plan year. We will not sit back, and we just can't afford to do what we did last year. We almost missed our deadline to implement any increases, so we're not going to do that again this year. We came here to bargain. We've gone through our data. We've been sharing data for that reason. We're bringing these options here today, these different options, because in our opinion, avoiding an increase is not possible at this point. We know where our plan is. We hope that by pushing some new programs and things like that, that we could maybe limit future increases. But we are here to negotiate and to seek an agreement. So, and I do believe that's what we all have a right, an expectation to do by meeting here at the table.
Understood. And maybe we could caucus so we could speak as a group, but we certainly believe, CTA, that more information can't hurt. We're not at that point where we're in October, November, and it's a critical time period that we're already past the red line that we would have liked to have been finished by. And obviously, per the district as it relates to finances and the state budget, when that picture becomes more clear, that further informs decisions about money, whether that's healthcare or raises as well. So that's a variable of consideration for us as well.
Well, if I could speak to that, I mean, That was presented at the Budget Advisory Committee as well as the last budget workshop in April. The legislative session, started in January, closed in March, so we do have the available funding. So the available funds for salary and benefits is $38 million, because it is one bucket of funds that we have available. So after taking into consideration those costs that we have to reabsorb back into the general fund, increases in categoricals, we have $38 million for both salary and benefits.
Two questions. One, is that number inclusive or exclusive of the teacher salary increase allocation from the state?
It's inclusive.
Okay. So if we could, it doesn't have to be right now, but if you could provide us the broken down numbers, because I know we would be interested, and I'm sure the other bargaining units would be interested in segregating the money that can only be used for teachers, so that that $38 million figure is more clear to us what's available to who. And then second, so based on what you just said, if any bargaining unit were interested in beginning salary negotiations in the near future, the district is open to that?
If we are ready, yeah, we can begin discussions on that.
Okay, all right.
For ours, it's a little different. Obviously, our contracts, begins on July 1st, where some of the others wouldn't, because theirs doesn't, it wouldn't
Understood.
go in until January 1st of 2025. But we would have to set some dates and see what we can do.
Okay.
But at that being said, those negotiations are separate. Last year, they were combined a little bit too much, and we won't go that long this time. We will not overlap negotiations like we did last year, because it presented quite a challenge for us, where we're actually seeing the impact of it now, where the increase that we're seeing, that we're going to, we're suggesting we have to impose here this year is greater because we did not pass anywhere near what we needed to last year. We all know that we came to that decision, in, was it October, or late October, or something like that, and things needed to go out beginning of November for open enrollment. So we just will not wait, and we're really not interested, as you brought up during last negotiations, commingling the negotiations. That did not go well. And so from our position, we're not going to enter that, if that's what you're asking.
No, I think it might be more of a nuance to it. We agree, obviously, that they can't be tied to each other, but obviously both parties have, it's money and it's a pot of money, so there are implications to each decision that each side weighs. So that's all I meant by that. Yeah, if we could caucus with our group just to touch base.
For your information, so this is what was presented at the Budget Advisory Committee as well as the budget workshop back in April. So the increase in the teacher compensation is $12.45 million of the $38 million.
And not everybody at the table probably understands, but that's actually has to be used for teacher salary and nothing else.
It does have to be used for teacher salary.
So when we talk about other groups, they would not be inclusive in that $12.4 million.
No, but when we look at what we're setting aside for a district, we always combine the two. So it's a total amount available for salary and benefits of $38 million, and $12.5 million of that is dedicated for teacher raises. In the past, we've always tried to do better than what was provided by the state legislature. It is difficult. This is a difficult year because it is the year that the ESSER funds are sunsetting. But so the total amount we have available is $38 million, inclusive of the set aside for the teacher salary categorical. Well, it's no longer a categorical. It's actually now in the base student allocation, but it is still a set aside within the base student allocation.
So they didn't, okay, so it's not specific as it had been the last 2-3 sessions. Yeah.
Right, they rolled it into the base student allocation, but they still give it to us as a separate page saying you need to make sure to set aside this amount.
Understood.
Any other questions? All right, we'll step out. You guys could have the room.
Thank you. So first, we appreciate the additional information and the updates that are corresponding with the monthly data and what's been presented today. We received your offer today. The coalition wants to meet and speak with our respective boards and some of our members to evaluate our position and then get back together and develop a response. So that's what our position is at this time.
Okay, we have, our next session is May 30th. My recommendation would be then that we find time to meet again in May before that, so we have some more sessions. Does anybody have their availability for the month of May?
I just know that the 30th is not good for the PBA. That's the last day of school. There's no way we'd be able to break to come here.
Okay. Did Katie accept it? That's the next one on the schedule. We can schedule some virtual sessions if needed, but we do need more sessions. We know what the data looks like. We're not just going to table this throughout the summer like we did last year.
We understand. All we're asking for is appropriate time to develop our positions.
Okay? We will float some days out there for May. If we need to get a couple sessions in, we're open to it. But once school gets out, it's hard to bring everybody together. So we do expect to have some sort of, make some progress on this during this school year. So that is our position on that. So we will send some, any data that you need, please send those requests to either myself or Caitlin, and we'll get that to you. And then we'll float some dates out there for everybody to consider, whether it's in person or virtual. Either is fine with us.
Okay.
Okay? All right. Thanks, everybody. Have a great day.
Thank you.